Just to reiterate, we have a small technical glitch, and so we will start at 11:05.
Oui, bonjour à tous. Nous avons quelques difficultés techniques et nous allons commencer dans 5 minutes. Merci.
We are ready to start.
Hello, I'm Dr. Fiona Thebwe and welcome to the WHO Africa Media Briefing, which is taking place in collaboration with APO Group. First, some housekeeping. You can choose the language in which you'd like to hear the press conference by turning to the globe on the bottom right and selecting your language. And as always, we shall give you an opportunity to ask your questions to our panelists at the end, and to do this, please use the question and answer function of the Zoom application. Please remember, you will need to provide your name and the news organization you represent for your questions to be answered. Also, do notify us if you'd like to ask your question live, and we shall grant you the opportunity.
Bonjour à tous et merci de nous avoir rejoints pour cette conférence de presse de l'OMS. Si vous souhaitez écouter la conférence en français, merci de cliquer sur l'icône en forme de globe située en bas de l'écran à droite. Et lorsque vous posez vos questions, merci de bien vouloir préciser votre nom et le média que vous représentez. Au revoir.
Thank you, Yasmina. So joining us from Brazzaville, Congo is Dr. Richard Mihigo, the coordinator of the Vaccine Preventable Diseases Program. And now I will let Dr. Mihigo introduce our other panelists.
Thank you very much, Dr. Fiona, and good morning or good afternoon to all the journalists participating in this press conference on COVID-19 vaccine rollout in Africa. Dr. Fiona, I'm very pleased to be joined for this conversation by Dr. Pamela Smith-Lawrence, who's the Acting Director of Health Services in the Ministry of Health and Wellness here in Botswana. Welcome, Doctor. I'm also delighted to share the floor with Mrs. Fortunate Dembe, who's the Deputy Director of Pharmaceutical Services in the Ministry of Health in Eswatini. So they will all talk about the achievement of their countries in the rollout of COVID-19 vaccine. So welcome, a warm welcome, dear colleagues. Africa has to date received more than 200 million vaccine doses and administered around 71% of these. 60 million people are now being fully vaccinated. which represent just over 4% of the total population in Africa. Today marks the deadline for countries to achieve the WHO global target of fully vaccinating 10% of their population against COVID-19. 15 countries in Africa have achieved this target. These results show some sign of progress, yet there's still a long way to go. So in the face of great adversity, these countries have shown the commitment and the resilience we need. For instance, Seychelles and Mauritius have fully vaccinated up to close to 60% of their population. Morocco, 48%, and Tunisia, Comoros, and Cape Verde, for instance, have vaccinated over 20%, while Eswatini is quite very close to that mark. Botswana, South Africa, and Rwanda are about to hit the 15% mark. So the most striking commonality between the countries that have achieved this target is their access to a steady vaccine supply. All of them have administered more than 25 doses per 100 people when we consider at least one dose. So most have had the resources to procure the vaccine or strike early bilateral deals over and above what COVAX was able to deliver. Unfortunately, 70% of African countries have missed this important milestone to protect their most vulnerable, with half of the 52 countries with COVID vaccination program in Africa have inoculated less than 2% of their population. WHO has gathered lessons learned from successful vaccine rollout and is supporting countries with greater challenges and bigger populations to apply them to their own context. So we really urge countries to push forward with the renewed vigor to fully vaccinate 40% of their population by the end of this year. As much as our actions count, so do those of our partners. While monthly vaccine deliveries have increased almost tenfold since June, we need the total number of vaccine delivery received to date to more than double by the end of the year if we are to reach the next target, which will be 40% vaccination of the entire population. So COVAX is working with donors to identify the countries that can currently absorb large volume of vaccine and send them their way. It is also identifying with the support indeed of WHO and partners, countries that do not have other means to procure vaccines, and will ensure that these countries are in the front of the queue to get enough vaccine to cover their priority populations. In addition to these efforts, we need pledges of doses by wealthier countries to materialize soon. So WHO stands poised for the last quarter of 2021. I'm glad to announce that starting next week, we are sending multidisciplinary teams of international experts to countries that are struggling to scale up their operation so that we can drill down and identify the bottlenecks so that the local authorities and their partners can remedy them as they continue to roll out the vaccine. This is also the opportunity indeed to invite all the partners to join us in this support to member states. New COVID-19 cases continue to decline on the African continent since the peak that we all observed in early July, dropping to close to 72,000 reported in the week ending September 26, with more than 1,700 deaths reported in 34 countries in the same period. So despite the declining number of cases, we must all remain vigilant and continue to adhere to the proven public health and safety measures that we know very well saves life, such as wearing a face mask, washing our hands regularly, and observing physical distancing, especially while vaccination rates remain low. So with this said, I look forward to our discussion today, and thank you for joining us.
Thank you very much, Dr. Mihigo. And now to you, Dr. Pamela Smith-Lawrence. Botswana has been mentioned to be one of those stars that we have that have achieved the 10% global milestone. Can you tell us how Botswana managed to achieve this 10%?
Thank you. Thank you very much, Chairperson. Good afternoon to you all present on this platform today. And I wish to also take this opportunity to wish my countrymen a safe and happy Independence Day. The development of the National Deployment and Vaccination Plan in collaboration with WHO and relevant stakeholders embraced a multidimensional and multidisciplinary framework espoused in the implementation pillars, which convened all stakeholders at planning, coordination, and implementation stages. The target population for our vaccine rollout program was all adults over the age of 18, which comprises of 1.5 million people in Botswana. As a self-financing country, Botswana sought to secure and procure COVID-19 vaccines using different available platforms. This process began as early as May 2020 and encompasses subscribing to global and regional vaccine access platforms, such as the COVAX and AVAT facilities. Additionally, the country engaged with vaccine manufacturers directly by signing bilateral agreements for vaccine procurement. We have also leveraged on existing diplomatic relationships with different countries to obtain vaccine donations. To date, we have managed to fully vaccinate 22.4% of our target population of 1.5 million, while 29.6% of this target have received first doses. Our vaccine program owes some of this success to the successful expansion of the deployment to a variety of stakeholders such as private health practitioners, as well as NGOs. Public vaccination sites have also been expanded to include community-based settings to provide an equitable and accessible service to all Botswana. As vaccines continue to arrive in the country, other models of implementation that we intend to use include drive-through models, as well as shopping malls for easy and convenient access by the public. Our robust public education and information dissemination initiative has ensured that any pockets of vaccine hesitancy are subdued. As a result, people always turn up to our vaccination sites in huge numbers, regardless of the vaccine being offered. Issues of vaccine preference do come up from time to time, but they're too insignificant to cause any meaningful concern. Botswana has been open and transparent about its vaccine procurement and rollout processes by sharing timely information with the media and the public. The nation is kept abreast with how many people have been vaccinated and where the vaccination process has paused on account of vaccine shortages. All media inquiries on our activities are also responded to timelessly. In short, both the nation and the media have never been short of any information about vaccines. In addition, we have strong political commitment in deploying our vaccine program. So in summary, as a country, we have been united in our agreement that vaccines are the most effective pharmaceutical approach to fight against the COVID-19 pandemic and preventing deaths and severe disease. Thank you, Chairperson.
Thanks, Dr. Pamela Smith-Lawrence. That's quite exciting and enlightening. So now over to the mighty kingdom of Eswatini. Mrs. Fortunate Bembe, can you tell us about the lessons learned from Eswatini in its vaccine rollout?
Thank you, Program Director, and good morning and good afternoon to all our media and the people present. Of course, as a Kingdom of Eswatini, we have also attained and surpassed the 10% vaccination coverage. To date, we are standing at a national coverage of 18%. And what has assisted us to get to where we are, it's a number of factors. We have had political will where we saw the government commitment and a strong political will. As in early December, we had the head of state commit government to 200 million emalangeni for the procurement of COVID vaccines. And we also had additional support from funds that were raised by the private sector and some local foundations to the amount of 15.6 million for the procurement of vaccines. Also, the Ministry of Health's strong leadership role under the able leadership of the Honorable Minister of Health, Senator Lizinkosi, together with the WHO country office and the UNICEF country office, also played a pivotal role in the achievement of this goal. In country, of course, we had the appointment of the National COVID-19 Vaccination Coordinating Team, which was responsible for coordinating all vaccination activities in country, and the technical working group that was responsible for the development of the National Deployment Vaccination Plan, which guided all the activities surrounding the vaccination in country. This plan was developed with the involvement of all relevant stakeholders, both in public and private sector and our non-governmental organizations. Eswatini adopted a multi-sector approach in the delivery of vaccination services so as to bring vaccines closer to the people. We also put in place a digital system for vaccination registration, vaccinating, monitoring, and reporting, sending out reminders to the public for those vaccines that needed 2 doses when they were due to come in for their vaccination, so that they come timelessly for their vaccination. We put in place a control room, which was responsible for monitoring real-time data as vaccination was taking place on the site, so that challenges would be picked up timelessly and resolved timely. We also had timely review of vaccines, receipts, handling, storage, and also our cold chain, monitoring and transportation processes for the vaccines to the vaccination centers. We serviced our cold chain equipment in time before the arrival of our vaccines and made sure that our backup generators were working so as to avoid wastages. Also, we identified vaccination centers in time and communicated these to the public. Our vaccinating centers were divided into fixed sites whereby the public could come to the sites from Monday to Friday between 8 and 4 throughout the week. And then we also had what we called community sites, where we had teams going to the communities to vaccinate people. And we also had mobile teams that would go closer to the people so as to bring the vaccines as close as possible to the public. We're working together with our partners, Business Eswatini, the Look Commission, the private sector, so that we make sure that vaccines are available throughout the country. We also, in our risk communication and community engagement strategies, created messages through printed media, mass media, social media, community engagement. And we also had jingles and testimonials from survivors of COVID, both those that were vaccinated and those that were unvaccinated, so that we give public the information, create demand, dispel myths, address fears and questions that the public may have, and also to manage public expectations. We had ahead of the vaccination, we had a training of our able vaccinators so as to improve their skills. They were motivated, they were passionate about their work, which also promoted the public to come forward so that whenever the public had questions, they could also respond to those questions timely. We had vaccination trial runs, which involved senior management of the Ministry of Health during the beginning of the campaign, so as to create a buy-in for the public. We launched our vaccination program. We made a big noise about that. In our launch, we had then the acting Prime Minister. He came with members of his cabinet. We had members of parliament, of both houses of parliament. We had pastors, we had chief executive officers and very influential people who were vaccinated during the launch so that we create demand and dispel fears among the public. And then because of the scarcity of the vaccines in the initial stages of the vaccination, we prioritized some groups that were going to be vaccinated initially, that comprised of the healthcare workers and then the elderly. This was informed by our epidemiology data, which informed us that the older people were the most vulnerable during the first and second wave of the pandemic. However, as soon as we received additional vaccine, we quickly re-strategized and came up with an age tiering approach in vaccination campaign. We also carried out some targeted vaccination with the aim of opening up our economy and opening up our schools. So we targeted educators and teachers. We targeted the business sector. We targeted the transport sector responsible for ferrying people to and from. And also to create demand and hype, we targeted the Football Association, soccer players, supporters, the entertainment industry, artists. All those helped us to create demand for the people. Needless to say, the arrival of the United States donated Johnson & Johnson vaccine, which came through the COVAX facility, it was a game changer in the vaccination program in Eswatini, because that ensured that we had a lot of vaccines, and it also built the public confidence on the availability of these vaccines. So there was a high demand and people started coming in to be vaccinated, even though they were not in the called up groups. But what we did again, in order to avoid wastages, if we were vaccinating a certain age group and you came forward and you didn't belong to that age group, we asked you to wait until the end of day. At the end of days, those vaccines that were still remained within a vial, because some vials contained 10 doses, other 5 doses. If we still had doses remaining in the vial, then we will vaccinate those that do not fall among those age group, but have been waiting on the sidelines for these. So that ensured the uptake. Lessons that we have learned from this is that government commitment and a strong political will are necessary for the improvement of the uptake of vaccine. And of course, a close collaboration and transparent communication between our stakeholders and with the public, because the communication is key when it comes to the public, because it reduces the fear-mongering, the speculations, and it also helps to manage expectations. When the public knows that we have received so many vaccines and these are the target groups that will be vaccinating, and they will wait in line and they will know that as soon as we finish this, we're coming to this group, and then there will be no fears. They will know that they will be taken care of as soon as possible. Right now, the country is vaccinating everyone 18 years and above with the vaccines, but we also have an aim of going to the 12 to 17-year-olds when we receive our Pfizer-BioNTech vaccine, so that we ensure proper opening of the schools. We also learned that it is important to vaccinate early, because when we're vaccinating, we're within the third wave. So you'd find that as people were coming in because they were afraid of getting sick, some got vaccinated when they were already harboring the virus within their bodies, which was not good. So communication was sent out there that we have enough vaccines. Do not vaccinate if you are sick. Wait until you have cleared, and then you can come forward for vaccine. Also, keeping an eye on the social media so that you know what information is circulating out there and what the public is exposed to is key, because it assists us with our risk communication and community engagement messaging, so that we can help to respond to those information and dispel those myths and fears. And we had opened a lot of platforms where the public can ask, both the social media platform and WhatsApp platform, where the public can engage directly with the Ministry of Health so that these would be responded to. In a nutshell, I would say that's our experience as the Kingdom of Eswatini. I thank you.
Thank you very much, our dear member from the Mrs. Fortunate Bembe from the Kingdom of Eswatini. Now that we've heard from all our panelists, it's your turn to ask questions, our journalists. And to do this, please, as mentioned before, use the Q&A function on the Zoom application. And also remember that you'll need to provide your name and news organization you represent to have your question answered. We also have on hand Dr. Tieno Balde, the Deputy Incident Manager for the COVID-19 response, and Dr. Fiona Bracker, the Program Manager for Emergency Response with WHO Region Office for Africa. We also do have our 2 WHO representatives for Eswatini and Botswana with us. So now we shall go to the first question, and I'll hand it over to you, Lindsay Shattel with the New York Times, to ask your question live.
Good morning. This is Lindsay Shattel from the New York Times. My question is, in Malawi, we saw reports that approximately 27,000 AstraZeneca vaccines face expiry today. That number has been disputed and may be revised. And I wanted to know if, and the officials will probably have to destroy these as they did a couple months ago. And do we have any understanding about why the rollout is slow in countries like Malawi when it seems to be working in countries like Botswana and Eswatini? And then do we by any chance know why, for example, women have been slower to take up the vaccines as opposed to men? And are there any other alternatives to destroying the vaccines? Thank you.
Thank you, Lindsay. And I'll ask you, Dr. Mihigo, to take this question on.
Yeah, no, thank you very much for this question. I think we were also informed about this news, but we contacted our country office through the WHO representative in Malawi, and we got quite a bit different story of what you are reporting now. So on the Monday, 27 September, for instance, the stock that were yet to be used in Malawi was 12,600 doses. And after the discussion with the national authority, where many districts were currently at zero stock balance, we get the reassurance that these doses were, by the way, going to be used by yesterday, Wednesday. So there was no risk of wasting vaccine in Malawi. And the Ministry of Health colleagues wanted to even communicate that to the public to clearly reassure the public that all the doses that have been received in the country are currently being put at good use. Now, on the issue of women less vaccinated than men, we have a slightly different data at our level. So on overall, what we've realized is that in the region in general, we have almost a par between men and women being vaccinated. So we don't have a specific issue of gender disparity in terms of access. So there might be one or another case here and there, but in general, when we looked at the data that we are collecting from all the countries, there is no issue with vaccination of women. Thank you.
Thank you, Dr. Mihigo. Now we'll go to you, Daniel Arap Moy, with the Science and Development Network Kenya. With CGTN, to ask your question live.
Well, thank you very much, Dr. Fiona. Dr. Fiona, my question is, what are the implications of Africa failing to meet the September target, and what options are there for Africa?
Okay, back to you, Dr. Mihigo, and then we can have somebody else from Dr. Pamela Wayne about what implications, for example, would that be for a country like Botswana?
Well, I think the milestone of 10% by September and 40% was set globally to make sure that we have a global movement where we can have a protection of people across the world at the same time. The 10% by itself, it's not an end because this is not the ideal coverage, but it's just a process by which we hope most of the country will go through in protecting their most vulnerable people. One of the consequences clearly of not meeting that target is leaving many vulnerable population at risk of the disease. Though we have seen that the number of cases have started to being reduced, but as I said in my opening remarks, I think we believe that it's more than important to continue to use other non-pharmaceutical measures to keep this trend on a down size. So clearly the consequence will be the continuation of transmission across the countries, and delaying the reopening of economy, delaying reopening of schools, and getting back to a normal lives in many places. So the real strong appeal here is to accelerate the pace of vaccine rollout in the continent. We just crossed one milestone, but we have another important one by the end of the December 2021, where we need to improve and expand the experience in rolling out the vaccine so that we can protect as many people as possible across the region.
I realize that Dr. Mihigo, you have answered that question really well, and you talk about the 40%. We have our next question from Le Monde for you again, and they ask, WHO called for vaccine sharing for months, and lots of promises have been made by rich countries to donate doses. However, the 10% target hasn't been fully reached. How do you explain this failure, and how do you feel about the next target of 40% by the end of the year? And there's a second question to that. Apart from dose donations, calls have been made to rich countries to give their places in the vaccine queue. Can you tell us more about this? Did rich countries answer the call and give their slots in the queue? Over to you, Dr. Mihigo.
Yeah, thank you, Fiona, for this question. So as you know, in the margins of the UN General Assembly last week in New York, I think there was a global summit on COVID-19 where leaders across the world gathered together again to discuss the issue of COVID-19 vaccine rollout and the need really to accelerate the pace in terms of delivering vaccine, mainly to low-income countries. So it's clear that that summit came up with renewed commitment to accelerate the vaccine. We heard vaccination, we heard very nice pledges that were made by not only the United States of America, but by other countries committing not only resources, but also to accelerate the pace. So what we are calling really at WHO, I think since the beginning, is really to translate those commitments into real delivery. We have seen indeed an acceleration in terms of vaccine delivery in September, compared, for instance, to August and even previous month. But the shortfall for reaching the 40%, if we looked at all the vaccines that have been announced in terms of pipeline through COVAX and other donation, we are still standing around 100 million doses as a shortfall to reach the 40% target. We will need around 900 and something million doses if we take the assumption of 2 doses per person to reach the 40% target. So I think this is time really now for wealthier country, for COVAX, for other initiative like the AVAT, the African Union-led initiative, really to accelerate the pace so that the vaccine delivery can increase and we can absolutely work together to support country to reach those 40%. So I can say that we are still hoping that we are going to get there, because in Africa, what we can say, the major issue has been a supply issue rather than a demand issue. We have seen here and there some issue related to vaccine hesitancy, but the major problem so far that is hampering to reach these targets are a supply issue. Now, with regard to the second part of the question, in terms of the calls that we've made previously for some countries to provide, at least to allow COVAX and other countries to be in the front of the queue, I think we are yet to see that materialize. There is a need to continue some advocacy around that, because as we know, there are many countries now moving to a third dose, which will require additional doses for the booster that may indeed put our objective into risk. So we will be following this quite very closely, and we hope that we can work all together to reach this important second milestone of 40% of population by the end of December 2021.
Quite optimistic. Thank you, Dr. Mihigo. Dr. Smith-Lawrence, we heard from both Botswana and Eswatini about the supply issues that slowed down the vaccination. So now we go to a question from Naftali Mwaura, who is with Shinwa, and is asking, have we tackled the vaccine supply hitches that slowed down inoculation targeting high-risk populations? And you could tell us how Botswana did indeed tackle this.
Thank you very much for that question. Indeed, as Dr. Mihigo has mentioned, vaccine supply has been coming in small doses. But at least with our delivery schedules by the different platforms, we at least every month, we are expecting some vaccine doses to keep the public assured that they will be vaccinated. Earlier on, there was a mention of priority groups or high-risk populations. And indeed, I must admit that in our vaccine deployment plan, because of short supply, we have included certain individuals or priority groups that we consider either high-risk exposure to the disease itself or some that we call essential service providers. And in this regard, they have been considered from time to time with the small vaccine supplies that we have received, so that they are covered and protected as a way of protecting the economy of the country. I must say that so far we have received 1.2 million doses of vaccines in the country, which has just about covered over 500,000 people in the country. But we are expecting in the month of October, at least as early as this Saturday, 300,000 doses of AstraZeneca donation from the German government, as well as some 170,000 doses of Moderna directly procured from the manufacturer, and more donations of Johnson & Johnson, 50,000 doses have been donated from South Africa. So we hope that by the end of the year, we should cover at least 60 to 70% of our target population. Thank you very much.
Well, thank you very much. So now we go to two questions from Reuters. Aynat Mercy from Reuters. The first question comes to you, Dr. Mihigo. Many African health workers remain unvaccinated. Can you please comment on the progress of vaccine campaigns for health workers on the continent? And what are the challenges to getting more health workers vaccinated? The second question goes to you, Dr. Fiona Bracker, the Emergency Response Manager. Do you expect any resignations from members of management following the release of the report detailing sexual abuse by health workers in the DRC? Over to you, Dr. Mihigo.
Thank you, Dr. Fiona. On the first question, indeed, we are collecting data in vaccinating of special group like healthcare workers, but also elderly population, people with special condition. And what the data is showing us from the 39 countries where we were able to collect that information, 8% of all the doses administered in those 39 countries were administered to healthcare workers. Now, it's true that the variation across the country exists, where some countries have reported up to 15–20% of the doses administered, which have been going to the healthcare workers. So the only issue we have seen, it's, let's say, the wide definition of what we can call healthcare worker in different countries, who is being considered as healthcare workers. Is it the people who are on duty, nurse, doctors, pharmacists, and others? But we've seen in other countries, they've expanded that notion of healthcare workers to include community healthcare workers, to include people who are supporting the services, etc. So what we can say here, if we take the assumption, and this is the numbers which we were working on of around 4 to 5% of the population be healthcare workers. So many countries have done quite a very good job in targeting this specific group in their vaccination campaigns. But what we are really trying to monitor now is to really disaggregate those numbers and then to see among, let's say, the 8% who have been vaccinated, the healthcare workers, what does it mean exactly? How many nurses are remaining to be protected, and etc. So in conclusion, I can say we have seen quite a very good strategy of many countries targeting specifically healthcare workers, but we cannot indeed rule out that some places, healthcare workers, particularly those who are working in remote places in a rural area, have not been immunized. Because we have data as well that is showing us in few countries, the vaccination has only covered up to 50% of the districts. So it's not as opposed to other countries where they vaccinated elsewhere. So clearly showing that there could be some gap in reaching out the healthcare workers that should be prioritized in this campaign.
To you, Dr. Braca, for the second question.
Thank you, Fiona. First of all, I would like to say WHO apologizes unreservedly to the women and girls who suffered sexual exploitation and abuse during the response to the 10th Ebola virus outbreak in Eastern DRC. I echo the sentiments of all my WHO colleagues, the Director General and the Regional Director for Africa, to say how truly sorry we are that these women and girls did suffer these acts. We thank the survivors for their courage in coming forward, and the Director General has promised swift and immediate action to address the recommendations of the Independent Commission. And these actions will include provision of support and justice for the victims. It will include addressing management and staff failures, and in also a wholesome change or reform of the organization's structures and culture when it comes to prevention of sexual exploitation and abuse. The Director General has promised to have a comprehensive plan within the next 10 days. I'd also like to add that the Independent Commission did recommend that further investigation be done to identify individual responsibilities for the failure to activate investigative procedures. So it's a bit too early to tell whether there will be resignations from the staff. We'll await the investigation findings.
Thank you, Dr. Braca. And indeed, we do continue to apologize to the populations that were affected. So our next question is directed to you, Mrs. Fortunate Mbembe, and it's from Bonisil Makubu with Times of Eswatini. Can you highlight 3 measures of preparedness for the 4th wave of COVID-19 and outline how these would work better than they did during the 3rd wave? And possibly Dr. Balde, Tieno Balde, you could come in and tell us how the African region is also preparing for the next wave.
Okay, thank you for the question, and sorry for that hitch there. Yes, as Eswatini, we are now preparing for the 4th wave, and part of the measures that we have put in place for the 4th wave, of course, is to try and scale up the vaccination process. That is why now we've taken the vaccination to the schools So we're visiting all respective schools to vaccinate all the eligible learners that are 18 years and above, so as to ensure that we can keep our schools open as we go through the waves. And also we are calling up individuals to come forward to vaccinate now when our figures are still low, so that their bodies will build up the necessary immune response ahead of the fourth wave, because we saw the dangers of vaccinating people when we are already surging as a country. Also, as a country, what we have done is we have highlighted in the beginning that the head of state committed government to 200 million emalangeni for the procurement of vaccines. We've utilized some of those funds for the procurement of the Pfizer-BioNTech vaccine directly with the manufacturer. We have procured 400,100 doses of that through Pfizer. And we're also expecting 100,625 doses of the same through the COVAX facility. We're going to utilize those vaccines to vaccinate all the eligible people, 16 years and above, but we're going to go further and take these vaccines to the children 12 years and above, because we know those are still the learners that are going to schools to ensure that schools remain open. We're already building capacity towards an oxygen generation within our facilities, so that we can boost oxygen generation throughout our treatment facilities, because we saw that during the third wave, that helped us immensely in the treatment or the management of our COVID cases. So we are also scaling up that issue of oxygen generating plants, and also having bulk oxygen tanks within our hospitals, so as to ensure that a lot of people are saved with this initiative. I thank you.
Okay, thank you very much. Great preparation you have there. So our next question will come from Paul Adepoju with Health Policy Watch. Please go live with your question.
Yes, thank you very much for this opportunity, and congratulations to the various countries mentioned for the achievement. I'd like, my question goes to Dr. Miego. Is there an update regarding the development from the UK regarding vaccination exercises happening in Africa and the restrictions? I would also like the countries represented on this panel to also share what their thoughts regarding the UK government's policies regarding travel restrictions affecting African countries. Thank you very much.
Okay, no, thank you for the question. So with regard to the UK restriction on the travel, on countries that have been put on red lists as opposed to others countries, I think we have been very clear right at the beginning of this, and you remember the issue that was even before that with the AstraZeneca vaccine that was not recognized by the European Union member states, some of them. Fortunately, this has changed in the good direction. I think we first of all recommend that most of the vaccines that have received WHO emergency use listing have gone through a very rigorous evaluation system. And fortunately, many countries are now recognizing the WHO EU vaccine that have been listed for emergency use in their programs. Now, with regard to this specific issue with the UK, indeed, this is something that we are still consulting to try to understand very well what is the real issue. It looks like the issue is not the vaccine itself, but the documentation around this vaccine, because we need to remember that the UK has been one of the countries that have provided a lot of vaccine donation to the countries in this region. So we can't ask those countries which are using vaccine that are coming from the UK to say that those vaccines are not valid. And I think Africa have got a huge experience in rolling out vaccination. We've eradicated wild poliovirus on the continent. Many diseases are currently under control. We have a very strong vaccination program in many places. So the issue is not in terms of reliability of vaccination program. So we try to understand very well what are the consequences around that. And indeed, anything that can prevent free movement of people, particularly in this time where countries are struggling to put the economy back on track, is something that we should avoid globally. So I think this is what I can say on that.
Thank you, Dr. Smith-Lawrence or Mrs. Bembe. Would you have something to add?
Okay, thank you for the question. What I would add is that as Eswatini, and of course, we are working hand in hand with our partners. And of course, we liaise with other member states, both surrounding and those outside Eswatini, like the UK, because we are cognizant of the fact that no one is safe unless everyone is safe. So even if Eswatini were to vaccinate and attain 80% vaccination, if our neighboring countries are not doing well, they are doing poorly, then we are not safe. So we have to help each other and handhold each other to ensure that we vaccinate as much people as possible, so as to ensure the safety of everyone in the continent. Of course, with respect to the acquisition of vaccines to try and vaccinate as much people as possible, we have approached some of the European countries like the UK, where we are carrying out an effectiveness study with AstraZeneca to show the effectiveness of this vaccine in reducing the incidence of death, in reducing the incidence of severe disease, with the aim of building public confidence on these vaccines. But also, the other hand here, it was also one of the ways in which Eswatini was to acquire additional vaccines for the vaccination of its population. That's why we had to approach AstraZeneca to say we'd like to carry out this study. And then in exchange, we had the acquisition of the required vaccines to carry out the study. So we have to work and think outside the box as we move forward. I thank you.
Thank you. Indeed, no one is safe until everyone is safe. And it's good news that we've heard that the UK is planning to lessen these restrictions on vaccines starting tomorrow, the 1st of October. So now we go to you live from Nairobi, Rhoda Odhiambo with BBC Africa.
Thank you, Dr. Fiona. My name is Rhoda from BBC Africa. I have two questions that one is addressed to Dr. Mihigo and the other one, Mrs. Bembe. From the list of countries that have been able to vaccinate at least 10% of the population, how comes it's relatively smaller states that have been able to do so well compared to highly populated countries? If we were to compare an like Comoros, for instance, and Nigeria, what is it that Comoros was able to do that Nigeria or perhaps even Ethiopia was not able to do? Would we consider the donations they received earlier on before they got the COVID vaccines, or what made a relatively smaller states be able to achieve this goal? And to Mrs. Bembe, perhaps she'll be able to answer this. If we look at how the African continent has been able to roll out COVID-19 vaccines and how each country has been able to come up with targets, a different target, would a country's culture also have to play a role in this? If a country perhaps has an individualistic culture or a communal culture in how vaccines are rolled out. So for instance, as opposed to having one person going, they'll call the whole community to go and get vaccinated.
Thank you, Rhoda. Over to you, Dr. Mihigo. And then Mrs. Bembe.
Yeah, no, thank you very much, Ms. Odhiambo. So I think if we looked at all those 15 countries that have managed at least to vaccinate more than 10% of their population, there is a variety of countries. Indeed, some of them, if not many, are small countries with small population. What we need to understand here, it's 2 or 3 things. The first one, it's the complexity with which this vaccination campaign have been organized. Here we are talking about vaccinating 10, 15, 20, 30% of the entire population in a very short period of time. One of the issues that many countries have been struggling with, as I said, since the beginning, was supply. And if you looked at the way supply was allocated through, for instance, the COVAX facility, it was following a percentage of the population to make sure that everybody gets an equitable share of the fewer supply that were existing at that time. So clearly, if we say 5% or 10% of the supply that are going to cover Nigeria compared to small countries, so the number of doses were proportionate to its population size, quite very small. And the smaller country were indeed able to accelerate the pace in terms of delivering of these vaccines. But we are learning quite a great deal of lessons, even in a country with a huge population. And on the list, for instance, we have countries like South Africa, we have countries like Morocco, Tunisia, that have a relatively a big number of population, but manage to deploy these vaccines at a quite a very rapid pace, pretty much the same way as what the country with smaller population have been able to do. So what I said in the beginning, we are putting together, mounting an operation where we're going to send people, multidisciplinary teams in the countries that are struggling to roll out the vaccine, to try to drill down and understand really what are the issues that are pertaining to the slow uptake of the vaccine, and then work together with the partners and the Ministry of Health in particular to make sure that this country can be ably supported to accelerate their pace. So we are quite confident that in this second phase, the focus that we are starting to shift towards those countries, particularly with a big population, will hopefully yield the result that one would like to see in increasing the coverage.
Thank you. Over to you, Mrs. Bembe.
Okay, thank you for the question. And indeed, culture does play an important role in the uptake of this vaccine. I know this has been posed to us as one of the cultural countries in Africa who still have a wealthy cultural background. And what we've seen is that culturally, the way we communicate with people and the way we mobilize people socially for these vaccines had an important role to play. I did mention during my presentation that among our strategy of vaccinating people where we had fixed sites, and then I said in addition to that, we had community sites. So in community sites, that's when we used community structures called Tinghundla. We have 59 Tinghundlas in Eswatini. So we had one of our partners that we're working with in our vaccination campaign go into these Tinghundlas and closer to the people, working with the chiefs, working with the Tindunas in order to mobilize the people to come forward for vaccines, and then we vaccinate them. So in our experience, culture did play an important and a pivotal role in our attainment of the 10%. Thank you.
Thank you. So now we have a question for you, Dr. Mihigo, from Antoine de Messene with AFP. Why is WHO backing the technology transfer hub led by Afrigen and Biovac in South Africa? And do you think it is important for Africa to have regional and independent vaccine production capacities in future?
No, thank you, Dr. Fiona. No, absolutely. I think one of the lessons, and maybe the bitter lesson that we've learned throughout this pandemic, it's how Africa was almost 100% dependent on the vaccines that are being produced that are coming from the outside of the continent. And the obvious consequence of that was that many countries, and we heard from both our colleague from Botswana and Eswatini, who wanted even to buy vaccines by themselves. Sometimes it was very difficult to get the vaccine because there was no vaccine out there at all. So I think having local vaccine manufacturing capacity in the African region become quite a very strategic issue for health security in this region, to make sure that the supplies, being vaccine, being also some of the other equipment, can be readily available closer to the people if we have another pandemic. And even beyond another pandemic, to make sure that we are ending this current one, we will definitely need to have those supply there. So WHO, by backing that, is really working in that spirit of making sure that we are working in the objective that was set up by the African Union to increase the capacity of member states in the African region to do vaccine manufacturing locally. So it's not only South Africa, there are many other countries, Senegal, Morocco, Egypt, we heard Algeria that's starting also to produce, Rwanda that's planning to do so. And I think that diversity across the continent will definitely, beyond the COVID-19, also hopefully provide the opportunity to produce other vaccines on the continent to deal with vaccine preventable disease at large, like malaria, TB, and why not HIV in the near future.
Indeed, there is hope. Now, before you leave the floor, Dr. Mihigo, we have a question for you, still from Sarah Jerving with DEVEX. Can you please talk about why pledged doses are not making it to African nations faster?
I wish I can find the answer on that. I think, as we've said, we salute the willingness of a healthier country to provide a donation. But I think that donation needs to be really translated in concrete action and sooner. So it should not be a leftover. While they've finalized their vaccination, then they need to give whatever has been left beside to the low income countries. So it has to be, and we heard this very clearly from our colleague from Eswatini, we are not going to get protected, all of us, if few people still remain at high risk. So we hope and we are calling again for an acceleration of these pledges. This was quite a strong message that came out from the Global Summit on COVID-19 vaccine in the margin of the UNGA. So we hope that we are going to see more vaccine coming, and maybe more importantly, to get some space for countries that can afford to pay the vaccine, that they can get the supply on the market as well.
All right, we are coming to the end of this virtual press conference. Now let's turn to our three panelists and hear any final messages, and I'll request you to keep your remarks to just 1 minute each. So I'll start with you, Mrs. Fortunate Bembe from Eswatini.
Once again, thank you for inviting Eswatini to share our experiences with the journalists and the panelists that are here. Our take-home message is that you cannot do it alone. So we need to work together in this vaccination exercise. A case in point is Eswatini. We just looked around and looked at who has had a successful vaccination exercise. And we saw that Israel up there had successfully rolled out this vaccine. So we went to them, we approached them and asked for help to say, how did you do it? We wanted to learn from them. So they brought a team from Israel Aid, whom we are currently working with as we roll out our vaccine. So let us not be afraid to ask for help. Let us not be hesitant to learn from each other. I thank you.
Very interesting. Over to you, Mrs. Dr. Pamela Smith-Lawrence.
Thank you very much for this opportunity to share with you our experiences in Botswana. But what I can say at this point is just that we continue to engage with all our stakeholders and partners in health and unite in the vaccination program to get as many people vaccinated, including hard to reach and marginalized populations, as well as those that we term the undocumented migrants. So we are really prioritizing an equitable and fair distribution of vaccines in the country through very important partnerships with our stakeholders. Thank you very much.
Excellent lessons right there. And as we come to you, Dr. Mihigo, for your final remarks, I would like you to also answer Babaka Balde's question. Babaka is from Radio Kayar in Senegal. Why are vaccination rates so low in our countries? Is there a problem with the availability of vaccines, or do populations fear the vaccines?
Dr. Fiona, let me first say that on behalf of Dr. Moeti, the regional director, who has been quite a strong advocate of vaccine rollout in this region, and who unfortunately was not able to join us today because of other competing priority. I would like really to thank our two guests from Botswana and Eswatini. So thank you very much. I think we've learned quite a great deal of your experience, and we wish you all the best in the journey towards the next milestone of reaching 40% of the population. Secondly, I would like to reiterate WHO commitment in terms of continuing our efforts to support country to stay focused on these different milestones and objectives, working with all the partners to make sure that the needed supply can get to where most people need. And then finally, on the question from our colleague from Sénégal, if I can respond that in French, je pense que nous avons discuté longuement de la situation de pourquoi certains pays n'avancent pas. Et je pense que malgré certains petits soucis ici et là de rumeurs contre la vaccination, le grand problème dans la plupart des pays reste malheureusement un problème de supply, un problème de vaccins. Nous avons constaté que là où les nombres de vaccins, les nombres de doses de vaccins augmentaient, la population venait chercher les vaccins. Donc, nous appelons encore une fois à tout le monde de continuer à observer les mesures barrières, et lorsque les vaccins deviennent disponibles, de faire tout pour se faire vacciner, car malheureusement, nous sommes encore en train de voir des cas de Covid dans beaucoup de pays, bien que le nombre de manière générale a continué à baisser. So, merci beaucoup et à bientôt.
All right, again, a big thank you to all our three panelists and also the backup panelists, and to your journalists. Have a good day, and we'll see you next week on the same virtual press conference. Thank you.